Welcome to ArchX implant training. Today we're going to be doing a demo of a placement of a zygomatic implant on one of our patients. Here we've taken a DICOM and we've actually converted it into an STL and printed it. So this is something that's very similar to what we do in our hands-on cases. You can actually send us a DICOM, we will convert it to STL, and then we'll print it so that you can actually do your surgery on your patient. So typically when we're doing a zygomatic implant, this case, severely atrophic maxilla, typically very minimal anchorage points, very difficult to do a traditional all-on-4 on this case. So we're usually anchoring to the zygomatic arches here. So when we're placing our implants, we're going to be placing in these areas here. Typically when I flap these cases, what I'll do is we'll need to make sure that the tissue moves all the way back here. So we have to create some releases. So typically what I'll do is I'll do a crestal incision. And I'll just draw this with the pencil. And I'll do a vertical release in the anterior right at the midline. Then after that, we'll also take our incision all the way back to the pterygoid region. Usually when we're doing these cases, we're also placing some pterygoid implants in there. So we want to make sure that this area all the way up back to the hamular notch, there's an incision there. And then we'll also, usually what I'll do is I'll run my finger right in the back here and I'll feel the zygomatic protuberance or the malar process. And usually I'll make my vertical incision about 1 centimeter in front of that. So typically in like the first molar region area of the arch is where we're making our other vertical release. Then typically what we'll do is we will raise our flap, and as we're raising our flap, I like to use a blunt-ended instrument. And basically we can use our areas where we have our releases to start our flap. And then what I like to do is we'll use a little bit of gauze, and we'll actually, the best way I've found to raise flaps is you'll press with the gauze. And as you press with the gauze, you can put some real firm pressure, and that pressure will help you move that flap all the way up. When we're flapping these cases, typically what we're doing is we want to flap. I'm going to mark some anatomic landmarks here. This is our malar process here, and this is our zygomatic arch. So if I hold this close up to the camera here, you can see. So this area right here, where the zygomatic arch intersects the malar process, makes an X. This is actually going to be where we want our insertion point for our zygoma. So typically when we're reflecting our flap, we like to see that, and we also like to see the zygomatic notch, and that's back here. So this is all the way back far here. So when you're reflecting your flap, you really have to reflect a good flap. If you don't get a good vertical release over here of at least 1 centimeter, it's going to be very difficult for you to reflect your flap, or for you to envision and see what you need to see. So the nice thing about a zygoma is it's done completely where you can see the entire process. So we've identified our malar process, we've identified our zygoma, and usually what we'll do is, even in the surgery, we'll take a surgical pencil, a sterile pencil, and we'll mark that. When you first get started, I think that's a great way for you to have a reference point. Usually right here, just past that X, just distal to it, you'll find the insertion point of the masseter muscle. And typically that insertion point for the masseter muscle, what I'll do is I'll take probably about 2 to 3 millimeters and just scrape along the zygoma so that I can release just a little bit of that masseter. So what we're not doing is we don't take a scalpel to that, because it will bleed excessively. But my point for that is to just get that masseter out of the way so that while we're drilling, we don't accidentally hit this area here and cause a lot of bleeds. So typically what we'll do is, once we've marked our spot, We'll start with a round diamond burr. I just use this on a 20-degree handpiece. And we'll make a osteotomy in that spot until you'll actually drop in to the sinus. You'll feel it once you've dropped into the sinus. Then I like to take a small curette and basically just make sure that there's no Schneiderian membrane around the area. So we'll just elevate that Schneiderian membrane. So once we have elevated the Schneiderian membrane, now we can move to our barrel diamond. And this barrel diamond is designed to not be end cutting. And basically what we do is we place the tip right inside of that area where we did the osteotomy. And then what we'll do is we'll lay that flat onto the malar process. And basically what we're doing is we're trying to follow this line here so that we follow the same angulation. Now, depending on how far back, if you're able to place a nice pterygoid implant in there, you may want to come a little more anterior with your zygoma for access points. So I can either angle my zygoma like this, or I can access like this a little bit flatter if I have a posterior implant. In this particular case, we're going to go and take this a little bit distal here, because we don't have a ton of pterygoid space to work with. So what I'm doing is I'm just generally laying this burr down to create a channel in the bone. Sometimes we'll use that little round burr, that round diamond, to kind of help get it started. And I'll use copious irrigation when we're doing this in the mouth. And I'll typically rock it back and forth here. And my goal with this one usually is I'll place it until the entire barrel is buried. And then I'll check my angulation to make sure that I am clear of the orbit. So in this case, the way that we do that is we have a special guide called the Zygo. This was invented by Sewon Oh, who's a great zygoma guy to learn from. But basically, this guide will just make sure we're clear of the orbit. We place the diamond barrel inside of it. And this is a really, really nice tool for us to use clinically, because as the diamond barrel fits in, then we can go ahead and close this. And what we're doing is, from a patient perspective, if there's skin over this area, we're feeling in this area where this little point is matching. So if we feel this area where the point is matching, we can actually feel the zygomatic notch, and we can also feel if this was a little more vertical, we could feel if this was hitting the orbit. So what we're doing is we're putting our finger right where this is touching. So this we get a palpation idea of where the orbit is. This angulation tells us we're very clear of the orbit, so we're in a safe position to place our zygoma. In this case, I'd probably just shallow it out a little bit more so that we can get a nice exit for the zygoma a little bit further interior here. So I'm going to shallow it out just a little bit more, and then we'll start our osteotomies. Okay, so we're going to go back in with our diamond and just shallow this out just a touch more. If you go little by little, it'll create a nice little channel there that you can follow with your burrs. So we're going to grab our burr here. And the first burr we'll typically use is basically just a lance drill. It will fit right inside of this osteotomy that we've created. And we're going to go ahead and advance it. We're going to need a little longer burr here for this one. We're going to advance it until we get through the cortical plate. So as we go here, you should see the tip come right out the buckle, just like this. So as soon as it goes through the buckle, we'll stop, remove our burr, and move up to the next size burr. So here's our second burr in the sequence. And this burr is a 2.75 burr. That first one was a 1.8 burr. 2.75 burr will go into that osteotomy, just following the same course that the diamond burr barrel helped us create that channel with. So that's our second burr. And then we're going to go with one more burr because this is a model. Usually in the mouth, I will just try my implant in with that. And usually it's pretty good, but we're placing a 4.0. So in this case, I'm going to go up to a 3.0 implant because the models are a little bit brittle. So I'm just creating a little more of an osteotomy there. And we're going just till the tip comes out. And you can see this clinically. When you have this retracted with your hand, you'll be able to see the tip of the drill bit go through. So once we've created our osteotomies, now we're going to go ahead. We can measure the site. Typically what we'll do is we'll place this little measuring tool inside of the osteotomy, and then I'll place it until I feel it drop into the zygoma area, and there's a little notch on the end of it that I'll pull. And when I pull that notch, I can tell exactly how long this area is. So typically, when I can rotate this so I can show you, there we go. This little notch right here is my measuring area. So this has a measurement of 50 millimeters. So typically I'll take about usually 2 to 5 millimeters off depending on how deep I want that placed. So I'm going to place a 47.5, or actually in this case a 45. So I'll get a 45 millimeter implant. And typically when we're placing our implant, we'll go ahead and use our insertion tool. And we'll introduce that into the osteotomy right through that channel that we created. And typically what we'll do, I put a little bit of pressure right on the neck of the implant as we insert. And when we go in, we'll feel our resistance, and usually I'll back off. So I'll go in about a turn and then back off about a quarter turn. So as we're doing that, we should be progressively placing the implant deeper and deeper into the osteotomy until we achieve nice cortical stability and we achieve our platform height that we'd like to see. So now we've got nice cortical stability here. Platform height is in a good position here, so that way you can see exactly where we're at. Okay. We can actually insert this one just a little bit more. So typically if I had a longer implant in here for the course of the demo, we can engage that cortical plate right there. Okay. Very good. Okay, so I want to take some time also to do the other side here. So we'll demonstrate the other side so you can get a good idea and see what we're working with the repetition on these cases. We're going to identify our malar process, which is going right here. Then we're going to identify our zygoma, which is right here. And remember, we're going to be removing that little 2-3 millimeters of the masseter right in that area. So we'll take that line and extend it up from the malar process. We'll take that line and extend it out from the zygoma. And that's our X marks the spot. That's our spot where we want to make our first osteotomy. Typically when we do that, we'll go ahead and use our, and get into a good position here for our camera here. We'll use our round diamond and we'll go right into that X spot, just distal to that X spot, and we will go until we enter into the sinus. And you'll feel it drop. And once you feel it drop like that, then we'll be able to clear that area out with the Schneiderian membrane. Once you clear that area out, make sure that you're not going to perforate that membrane. We can go in with our diamond barrel burr. So now we're going to use our barrel diamond inside of that primary osteotomy. We'll place the tip inside of it, and we'll just follow the malar, that line from the malar process. As we do this, typically, I'll go little by little and just very, very gently tilt that diamond burr little by little with copious irrigation. You've got to have a great assistant here that's going to do a fantastic job suctioning. You should always have your throat packs in place. Make sure that you have some extra suction. We have 2 suction units in each room. So 2 HVEs separately. 1 side delivery, 1 rear delivery. So as we're laying this down on the malar process, I'm placing this in place here until I can bury the entire diamond inside of bone. And that's why we use these barrel diamonds, because they're non-end cutting. So they are safer to use in these cases. So typically, that's what our channel will look like. We'll double check and make sure that we're clear of the orbit here by using our zygo. We'll take the barrel diamond off, place it inside of this little holder in the zygo. And then lay that right inside of the osteotomy and close it. And clinically, we'll feel this area here just to make sure that we're in a good position, to make sure that we're not in the orbit area. So we're just basically feeling with one finger and closing the other one in that area. So we can actually verify that we're very clear of the orbit. So sometimes if I'm doing a second zygoma in this case, I may flatten this out just a little bit more. In fact, I'm going to use that little round diamond to kind of flatten it out just a touch more. So I'm just going to take this area and just flatten it out just a little bit more. Now we're ready for our osteotomies. We'll start with our lance drill. Again, this is the 1.8 drill. And we'll lay this 1.8 drill right in that same little channel that we created with the diamond burr. Now we're just going little by little. Again, use copious irrigation for these. These straight hand pieces are very, very nice. So we'll go ahead and progress with this lance drill. And you should see it come out the buckle. As we progress, we see it come out the buckle. So we've gone through, we can see it right there. And if you've got a good enough flap in there, you should be able to view that during your surgery. I like to always view these things. That's an essential component of doing these surgeries, is being able to lift these flaps. So then what we'll do is we'll go to our next drill. So this is the second drill in the series. As we do our second drill in the series, we'll progress through the cortical bone. And these models are pretty realistic. They're very, very solid. Because they're so solid like that, they do feel a lot like cortical bone. So we'll go, sometimes when we place these, if you have a lot of implant and bone, like this case, you'll start to see these. We'll go all the way until the tip of the burr comes right out of the other end of the zygoma. So that was our 3.0 burr, or sorry, that was our 2.75 burr. We're going to move up to our 3.0 burr. And we're placing a 4.0 diameter implant here on this one. So we're working up to our 3.0 burr. Once I've gone through the cortical plate here, now we're all set with that. We don't need to go anymore. We're going to go ahead and measure our position for our implant next. We'll use our measuring tool here. And once it goes through, we'll pull back and take a look right here at the crest of bone. And this one also is going to be like a 47.5 implant there as well. And we'll go ahead and grab our insertion tool. With these, I like to make sure that I have a nice solid insertion tool, a new one. So we replace them once a month. And then also the other great drivers for these is called the Rosen drivers. It's a fantastic driver. It will fit this implant and we can actually place it without losing the implant. So what we'll do is we'll introduce it into the osteotomy. So as I do this, I'll usually put my finger or my thumb on the neck of the implant as I start it. And once you start it, then you can kind of let the channel guide the placement. And again, what we'll do, we'll go in, usually a turn, and then back off a half a turn. I'm going to use my other hand here for the demonstration purposes. Usually we'll seat this as we're progressively seating these implants. You will start to feel the tip with the finger, or you can actually retract and actually look at it. So we've got very, very nice torque here on this case. And we've seated our implant. This is an ideal placement. You want to see the tip of that. Typically what I'll do is I'll usually cover these areas up with Zygoma. Usually we use that as our grafting material. And then we'll pull over the buccal fat pad to close over the flap on these.